Thank you very much for that introduction. So, I'm Karl-Johann Myren. I work at Alexion. Alexion is the rare disease business unit of AstraZeneca. And not surprising, I will talk about the importance here of including the indirect burden and indirect cost when you are assessing new orphan medicinal products from a health technology assessment perspective. And I will take the next 15 minutes here to argue why that is important and show you a little bit of the patient journey really and family journey when it comes to rare diseases. So most of the rare diseases or the people who are affected by rare diseases, these rare diseases occur in childhood. So this is a lifelong journey then that you are looking in front of you. So you can put yourself in the shoes of the parents then, so that you are expecting to have a child and you're joyful, you're happy, and then a few months after, or could be a year, you notice that something is not right? So you want to understand what you can do then, and you seek care. So this is really, of course, you go and seek care. You go to the hospital, you go to your local clinician, and it's difficult because many of the symptoms are similar to other conditions as well also. So many times it takes a long time to get the proper diagnosis. You are getting referrals to different clinicians, different doctors also, and you travel the country. You usually, if you once find the expert that can treat your condition and you can get the diagnosis, it's not usually where you live. So it's usually in maybe one or two centers in the countries. And it usually takes much longer to get a diagnosis in a rare disease than compared to more common conditions. And once finally diagnosed, it takes, you can then see that there's many times not an approved therapy. So, and if there is an effective treatment that exists or has been approved, many times that treatment is not reimbursed because of cost reasons. So this is a fact that many of people living with rare diseases are facing. So many of, maybe out of 7,000 of rare diseases, maybe 10% have an approved therapy available also. Why then is it important to include and focus on the indirect burden also and include that in the health technology assessments also? Well, you can see that from the patient journey and the family journey, it affects the whole family also. It's a lot about travel, as I mentioned. You have to go to the hospital, you have to go to many different treaters also. It's not only one, and it takes time also to find that. And many actually have to move. They move to the treatment center where you can get treatment for your child or for yourself. It also means that your whole family needs to adapt to this condition or this situation also, and it puts a lot of stress on the family. It's also put a lot of stress on the other siblings also that are not suffering from this condition. It also affects works, of course, because many times you need to go and seek care. And when you go to the physician, it's during office hours, right? So you have to take time off from work. You have to take time off from school as well also. You have to be away from school many times, many days also. So it's affecting your school progress. Another cost that is apparent to many of people living with rare diseases, you need also to make house modifications, alterations to your housing also. Everything puts a stress on the relationship also. You have a high divorce rate in people living with rare diseases also. Grief is another thing. It's not something that you can put a value on, but it's very apparent when you have a child, for example, and you know that child gets a diagnosis of a chronic condition. There is no treatment for that. And that also means frustration, lack of hope. It puts a lot of mental health issues and stress on the whole family. And I think a theme here is time. you have not enough time to capture everything that you need to do. So loss of time is very present for families living with rare diseases also. Stigma is another thing that is not included or measured, like social stigma and cultural stigma. And just to say that this is very common among people living with rare diseases. So they experience guilt, they feel blamed, they feel marginalized, excluded. So it's really stigma is really a critical health and social barrier. It's expressed in 1 out of 3 people living with rare diseases. 3 out of 4 parents report that their child face stigmatization also. And these are just a few statistics here that are very burdensome to the families, but are not something that you can put into, well, you can put it into the HTA assessment and so on, but it's not structurally measured in a way. So you see here a high percentage of the child face bullying, 44% that the child face mental health difficulties. Also that 27% mentioned that their child missed out on sports or on extracurricular activities. So this presents a picture that is showing that it's quite burdensome, and there are many areas that are important to people living with rare diseases. And for us, you and I, we take for granted everyday life and everyday life activities, and it's very different from patients and caregivers living with rare diseases. So it's a lot of stress on the caregivers, for example. So most of the caregivers are parents. It's also that I mentioned timing here, or time, that many of the parents are not able to continue working or they have to reduce the time that they're working. They spend a lot of time, more than two-thirds of the parents spend more than 2 hours on disease-related activities, everything that is related to their child or their own condition. So it's a lot of burden, and that also leads to the implications, mental health issues, depression, which is more common in rare diseases, or people living and families living with rare diseases also. And everything here also puts a lot of stress on the financial ability of the family also. Given that you're not able to continue working as you've done before, you have to reduce your working. You miss a lot of days at work also. It puts a lot of stress on your financial burden. And it's like a vicious circle also. If you don't have the money, it also puts pressure on your mental health and depression and similar, and also on the relationships as well. So many are actually single parents also, unfortunately, leading to that because it's very, very burdensome. And so this is a lot of things that are then not included. What is important to people living with rare diseases is not necessarily included or addressed in RCTs or in assessments. And why is this? This is from a survey that was performed in people living with rare neurology indications. So these are 8 areas that were mentioned by the people living with rare diseases, both caregivers and patients also. So these are some of the non-typical items that you include. For example, like occupational, personal development, that you don't have the same ability to do a career at work. You don't have the same personal development opportunities. There's a lot of disruption to your future planning. If you're doing a future planning in 2-3 years from now, it's easily disrupted by the condition. Emotional is a big piece here also coming up from people living with rare diseases. Sadness, hopelessness, loss of personal identity, self-esteem are things that are very important to people living with rare diseases. Sleep also, and that should be possible, of course, to include in clinical trials, but we rarely do that. And then, of course, again here, the financial implications here also, that you have less household incomes. And this also is affected in your social life, that you're not invited to parties, you're not able to go to social interactions because you are dealing with so many things with your condition or your child's conditions. So why then are we not including indirect burden and cost, and why are they not playing a more important role in health technology assessments? Well, from what I've showed here and what we see that patient and caregivers are no longer being able to do the things that they used to do. They are restricted in daily activities, restricted in their career, they are restricted in travel, you can't plan for travel and so on. You are restricted in your future education. And you lose independence also because you're becoming dependent on others also. So rarely that these areas of impact on the individual are brought into standardized assessment of rare diseases. The patient voice is of course heard, but it's more on not in a quantifiable way, but more on a case by case, like in the UK, like in NICE, you have the patient representatives, but it's many times dependent very much on the individual that is represented there. So if that is a great person that know how to express and explain the impact of this condition on their daily lives, that is great. But if you don't have that, you lose that. Also, or you don't have that opportunity. We lack clear guidance also from HTAs when it comes to indirect burden and indirect cost also. So there's an opportunity there. There are like areas where this is including, for example, the impact on quality of life, caregiver disutility, and also even indirect cost. But usually, especially in rare diseases, because of the uncertainty, they are usually not included or in the base case, so to speak, because there is too much uncertainty, too small populations, or even not pre-specified. We in pharma, we can do a much better job here, I think. We are not measuring this either in our clinical trials. It is difficult to measure, but you can do this by asking questions in the right way also. We model this most of the time, but I think there are opportunities here, of course, for pharma and industry to improve from this perspective also, and you just have to start doing this. So we need to change perspective. We need to have a fuller perspective. So this is just an overview from the patient perspective and the caregiver perspective, that you have the indirect cost also. But it's not only about cost here. It's also about the burden that you cannot put a value on. So I think both of these are very important here. So how should we then go forward? What can we do moving forward? I think one should start with a good example. One should look at the HTAs which have included indirect cost and indirect burden and accepted that also. Look at those good examples. Also look at industry or submissions where you have done this. Look at clinical trials where you have measured this. I know that it's not maybe the best way to include this or measure this in the clinical trial. You can use the open label extension period also, and you can use other ways of capturing. But I think it's at least look at the good examples and to some extent also formalize this, measure this, but have the flexibility also. If you start measure, you will be able then to see more. And it's up to the companies also. Start doing this, including this in your trial. Ask these questions to caregivers and the patients. And involve the patient advocacy as well also. Involve them because they know how their condition affects them on other areas, indirect areas, which I presented here also today. And have this early engagement also especially with the patient, but also with the HTA and the company. So by having those early engagements, it is a way also to potentially measure this in a better way and understand the burden of this condition on rare disease patients. So I stop there. Any questions, anything, a quick overview of why I think this is important to include and measure in the health technology assessment. I think this is maybe also something for JCA, potentially not now, but but for the future also. Yeah.
Alexion obviously is, taking a leadership in rare diseases, and it has been for years. If you had a wish list, okay, this is how you measure the mental state of a family, what is that you would tell HTA agencies and governments?
Yeah, I think you can do it in many different ways. I think it's also a reluctance to include too many instruments. And I think also if you ask the patients, they are responding to too many instruments in the clinical trial. So I think focusing really on what matters to the patients when it comes to mental health and target that really to what is important for that condition and that situation. But I think now we're not measuring unless it's like a depression-related or mental health condition, then we measure it, but we don't measure it. And I think we also are afraid from industry to overload the clinical trials with too many instruments as well also in that. So finding that balance, but we still do, right? We measure every second week and we throw the sink at them. So I'm more thinking about what should be the proper questions to include and ask the patients, and maybe how. And you may not be able, because it takes time before you can see the changes on indirect cost and burden, but you can see like how you can phrase the questions and capture in a different way to get that.
Thank you. Very interesting presentation. Do you think that the reason we are not measuring this is mostly due to a lack of data, which could improve with the European health data space? We will have access to more data and different types of data. Or is it more driven by some countries relying more on informal carers, or there's different levels of, let's say, providing social security services across Europe?
Yeah, I don't know why we don't do. I think it's one reason is because it's difficult. It may be difficult to measure this, and there is no approved instruments how to do this, and the focus has been more on the clinical outcomes and the endpoints in the clinical trials, and then you use modeling more to assess what kind of impact it could have on indirect, and then it's also like there are so few HTAs that actually accept the indirect cost and burden. It's like a secondary analysis, a scenario analysis that you can include, but it's the direct cost and the impact on healthcare resource utilization, hospitalization, ICU, and so that matters, that is included. But I don't know why it hasn't, because it's difficult, it shouldn't be a reason. I think also industry is a little bit to blame here. Why can't you do it? Why can't you just measure it and then present it? You don't have to have the guidelines to do that, but present if there is an indirect burden and you can do something about that with your treatment, you have to show that also, so you have to measure it. So I think it falls back on the industry as well.
Maybe building on that, thank you very much. A nice overview about the indirect burden. Very insightful. What kind of good country or HTA body examples do you see where you would say, okay, these are countries in Europe or globally which are more advanced in recognizing indirect burden and where others can learn from?
Yeah, I would like to know that. I don't think I have. I think there are like maybe pieces here and there from various agencies across, but not maybe one that stands out that this is we always take this perspective, make sure that if this is relevant, we will include it. I don't think that is, I haven't seen any, so I can't really, I think that the nice, when you have a patient representatives coming and presenting and talking and speaking, it can be very, very extremely powerful. But it's that subjective presence that this individual comes at the table, which, as when you have clinical experts, which are really convincing, that it's kind of similar. It's not this formalized way to capture it, but it's, yeah, I don't know. I don't have a good answer there. So. Yeah, yes, but.
Exactly. Does all HTAs that take societal costs sufficiently into their all HTAs that take societal costs into their criteria? TLV was the first one, and there's a group of HTAs. Yeah.
No worries, but I think this is the answer to Matthias' question. So we are not asking too many questions because we know that this is burdenful for the people who are doing the studies. And since we don't have a really good overview, and since most of the countries don't really care about those things, and we cannot convince our people internally to put all these questions in the questionnaire. But my original question was a different one, so thank you for this very good overview. Never seen this in such a nice and structured way. You summarized all the burdens on family and so on. You already were already talking about people who probably retire because they have a disease. I saw statistics that, and this was interesting to me also, that when someone experiences a cancer period, gets sick from cancer, this is the percentage of people who retire from cancer is lower than the number or the percentage of spouse or partners. So it's more partners who retire because their partner has a cancer period than they do themselves. So this was probably something to add also to your picture.
Yeah, I think that caregiver perspective is underestimated, especially for those burdensome, and when you have a spouse that taking a lot of that. You have Alzheimer's, of course, and other neurodegenerative conditions. So it's
and don't ask for HTA bodies who accept something like that.
No, yeah.
Thank you. Because we are talking about measuring and how to measure, sorry for introduction, I'm from AstraZeneca, Rucha, so we are the same organization. Yes. Yeah. I was thinking because one obstacle is that we don't want to send lots of instruments to patients to fill out the questionnaire. On the other hand, also, like quality of life questionnaire, etc., how they measure, they kind of cannot fully translate the impact what patients are experiencing, right? Would there be any idea that you have patients' baseline characteristics in the trial, some socioeconomic variables also, something like spouse getting retired or socioeconomic status in the country, something like this? Would there be an idea to have like all this information and translate, quantify it in certain way, disease specific? Like in this disease, for example, this is the ratio of like percentage of spouses' retirement or percentage of financial socioeconomic status decreasing by the time from the enrollment into the trial by the time disease progresses, and then define it in a way like in a very free format, but still like an initiative from industry to measure this in a quantifiable way, and not to replicate something which is very similar to those health state value answers or quality of life answers, because they, in my very personal opinion, they don't fully translate what patient is experiencing in a more dynamic level in the life, health, but also social dynamism. Yeah. So would there be any idea about that, or could we think of that?
I think so. I think a lot of the information that we actually are collecting today is not being utilized. Like we capture a lot of baseline characteristics from the patients and sometimes even from the caregivers, but the caregivers are usually not so much included in the clinical trial. So I think that could definitely be a possibility to utilize that. And we're talking about AI also. Could you use AI to maybe just when you're interviewing the patients at baseline also, and to get those nuances when it comes to different perspectives and how they are impacted, because it's with the quality of life instruments like EQ5D, you're not able to get those nuances and that those different situations that the individuals are facing. And then, of course, it will take time before you can see a change on a financial situation and so on. But it could also be something that you just interview and ask them, how do you perceive? Do you see that your symptoms now have improved so that you would be able to go back to work or to start working? There are ways of phrasing the questions and also making sure that they are validated and so on, so that you can work with the HTAs and regulatory agencies also to get that accepted.
Karl-Johann, I have one question, which is, you mentioned that the HTA agencies may discount quality of life information because of the uncertainty associated with it in rare diseases, because of low sample size, you know. How would we get over that same hump if you measure other things with small sample size, where the same uncertainty will apply if you measure spousal divorce rates or whatever else? How do you get over that barrier?
Yeah, that's a great question. I think you're facing the similar problem here as well. Also, maybe the effect size is bigger there so that you can capture it. I don't know, but we have in Alexion, we because of regulatory requirement, we set up large disease registries to follow the patients because of regulatory commitments. And those registries have been, but we collected 100 variables, but nothing on quality of life, but too much information. But I think that could be something also, and allowing for that possibility to come back and actually to show then that what we made as a promise actually would hold, so that you give that benefit of the doubt to the companies also and to when you're assessing this. So we're willing to come back, we're willing to measure this, but because of the small sample sizes and the rarity, we have ultra rare conditions, maybe a few patients in each country, even much more difficult. So you will always have that uncertainty, and that uncertainty will be on the indirect burden and cost as well also. So yeah, not a solution in my answer, but I think it's yeah, good question. Yeah.
Any other questions for Karl-Johann? In that case, thank you very much.
Okay, thank you.